Today I did not feel that whatever you did this that you did it absolutely right.
Good evening, viewers. Hope all of you are doing truly well. Series with Dr. Ashish Arbat, and we are going to talk about hip replacement today. The anatomical hip replacement, the dual mobility hips is what we are going to focus on today. But as usual, I would, of course, want to give you a quick input about our online health channel. Truwellth online health channel is an initiative of the Truwellth Integrative Healthcare, providing integrative and personalized health and nutrition advice to guide patients and healthy individuals to overcome their health concerns and manage self-help to reach the goal, the ultimate goal we call of holistic health and happiness. Truwellth aims to help you separate science from hype by sharing authentic knowledge and wisdom from healthcare and nutrition stalwarts so you can make the right health and nutrition choices. A quick note, viewers, this program, of course, is arranged and organized for education and spreading more as a personalized consultation for every individual is different, and hence we believe that they need an integrative and personalized consultation to prevent or cure illness. So for the same, you can reach us on 98200 or visit our website www.truewealth.in, and we will be very happy to connect you with Dr. Ashish Arbat. You can of course reach him, Ashish Arbat, to spread awareness about bone, muscle, and joint health, the various bone, muscle, joint ailments, injuries that are there, and the different techniques, the newer techniques, and their advantages uh, for actually curing these ailments that we are suffering from, and how an integrative approach with specific emphasis on physical therapy and nutrition can give us long-term benefits. What are the parameters to consider while selecting right techniques? At the same time, how to how a right surgeon can choose these right techniques with right implants for you so that you have better outcomes and quick recovery. So this really is our approach when it Dr. Ashish Arbat. He's one of the first 3D robotic joint replacement surgeons in Western India. He's a consultant orthopedic surgeon at Jahangir Hospital and the Sahyadri Hospital, Deccan, Pune. He is also present in Mumbai at the Curay Hospital, Aditi Hospital, Mulund, and the Ruby Clinic, Kalyan. He's, of course, MS Ortho from the coveted KM Hospital. He is MCH Ortho from the Royal College of Surgeons, UK. He is faculty for the UK MCH Ortho course. He has a fellowship from the Princeton University, New Jersey, under Dr. Jeff Abrams. He is the first Indian fellow under Dr. Ed Sugaya in shoulder and elbow arthroscopy, and he also has a fellowship from the Funabashi Sports Medicine, Tokyo, Japan. So you can see that he's very well trained and educated from all over the globe. And he has been associated with the IPL Gujarat, Pro Kabaddi League India, and Pune Wrestling Federation. Of course, sports is really his passion by he himself practicing it. And he has been proactively involved in devising the patient information system for the government of Scotland, but he's also very, very actively involved in various newer techniques that come. He studies them. He trains himself, and he trains a lot more doctors in it as well. So it's always a great time with him on Fridays with the Bone, Muscle, and Joint series. Dr. Ashish Arbat, welcome to the show as usual, and every Friday. It's a pleasure to have you here. And we are, of course, really looking forward to understanding this new technique with you, which will help so many patients who suffer from the hip pain and degeneration. And I'm sure a lot of women out there are also going to be very happy to listen into this because it is an excessive issue in women. but we would definitely want you to say a few words and then start off understanding really the anatomy and the causes really of hip degeneration that happens.
Hi Rajashri, and welcome. And this is our like the 13th
Yes,
show that we are doing, and very happy with. We have discussed robotics, we have discussed anatomical knee, we have discussed cartilage transfers, we have discussed regrow techniques of avian. But like last time when we discussed about regrow, it was always a issue when the hip degenerates or there is arthritis of the hip, and the question of replacement comes. It becomes mandatory to talk about hip replacements as well, because hip remains a very complicated area, and highest number of failures are seen in the hips, because worldwide hip replacements are done more than the knee replacements, because there are fractures, there are multiple causes of hip pain. And when we replace, a lot of considerations have to be done, because it is a joint which bears most of the weight of the body, and it is a it is the most important part of the body considering orthopedics, because hip, it's like our book Campbell. uh, it was a dichotomy written there that uh, the man, it is Hippocrates who had written it, the man comes from the hip and goes with the hip. So most of the time during those times there were hip fractures and people used to die because of hip fractures, old age issues. So man comes from the hips and goes from the hip. So today we are going to discuss our great hip, what is the latest in hip replacements, and all the other stuffs, what is robotics all about, and
yeah,
something known as a dual mobility hips, where you are able to sit down, do a lot of activities,
yes,
and again longevity of the hip, so that average the hip life, when people give 10 to 12 years, now we are talking about 40, 45 years of survival of the hip replacement. And what is that?
yeah. So, of course, we are going to look forward to your brilliant slides and animated slides which you show us. So, if you could help us understand really the anatomy of the hip, and why do we experience that much of pain, and sometimes which it seems like muscular, sometimes it just seems from more deeper down. When do we really understand that the degeneration is happening, and if we are a candidate now for a hip replacement, if you can explain that to us.
Yeah, I shall just share a slide with you so that we'll understand. Last time we had discussed about um, 1 minute, I'll just open the slide for you. So normal hip, there is the issue of 1 minute, I'm just opening the slide for you. There are too many PPTs that I'm going to share, so I hope so that what is happening. Are you able to see the slides, Rajesh?
Yes, yes,
Is are they seen?
yes.
So wait, sorry,
Mhm.
did I lose that PPT? Let me restart it again.
Sure. So maybe I can hold the fort till then, and
Yeah, you can. You can. I'm just
yeah, I am
arranging
going
the.
to I am going to quickly address the inflammation aspect of course, there's a lot of wear and tear when it comes to the degeneration of the hip, but intrinsically, I keep emphasizing on the fact that there is chronic inflammation as well as oxidative stress, and these are the two silent and most dangerous ones, which can affect our bones and joints. And what that does is that what it is actually doing to an apple, if you can see out here, that is exactly what happens to our cells. So, our cells are also dying out due to the oxidative stress that it experiences. It's not just stress, it is oxidative stress. That it means there are a lot of free radicals that are formed in our body due to the process of oxidation. Now, what exactly is inflammation and oxidation? These are really the processes which are our immune responses, and they are immune responses to the different types of toxins that we are inhaling, we're eating, bad lifestyle habits, and all that really causes inflammation and oxidative stress. And that really can affect our joints. And we've seen that in osteoarthritis, which Dr. Albert mentioned about the knee joints, and at the same time, the hip, which is a graver issue. And women, of course, when I said, we don't even have to mention the pain in the neck is nothing, but the pain in the hip is so much more prevalent. And what we see is that in this kind of inflammation, there are different inflammatory pathways in our body, the COX2, the LOX, the interleukins, the interferons that are actually causing inflammation. So there could be natural agents, which in my nutrition practice I keep advising. Dr. Albert, you can interrupt me whenever you're ready with your slides, and uh, I can't hear you.
We are ready.
Okay, great. So I'm just going to quickly finish this slide. So while you understand that these multiple pathways, and if there are good ingredients like cuckoos, which are age old, to MSM, and of course glucosamines, these are the newer agents that are found. They can actually help curb this inflammation and help actually curbing the damage. So I am really going to continue with the talk on nutrition and inflammation further down, but let's first really understand what the anatomy and the anatomy physiology really behind the pain and the degeneration that happens in the hip.
Yeah. So are you able to see it, Rajesh?
Yes, yes.
So this is us. We talk about 3D robotics and natural replacements. So patient-specific implantation. See, what happens is, like last time we discussed, that the degeneration of the hip. So there is a part of the hip that is the femoral head and the acetabulum, the cup. When these both degenerate, we need something called a replacement. Like last time we discussed that there is a stroke of the hip, and most of the cases that we do hip replacements nowadays is when this head starts degenerating with a disease known as avian, or there is a complex fracture of this part of the head, and something like this happens. So the head is completely degenerated, and the disease severity worsens with time, and there are multiple causes like last time we discussed. But when you lose this, what happens is there is a blood supply of the anatomy of the hip is like there is this is a ball and a socket joint with a synovial lining, and there is a white blue this cartilage on the cup here and the head here. When either of them get destroyed to grade 4, that is completely lost, the changes are seen in the x-ray with grading. The reasons for it mainly is alcohol. Most of the avians are seen because of excessive use of alcohol, that is 180 ml for at least 6 to 7 years. There are some steroids, that's one of the major causes. Then again, trauma, fractures, excessive sedentary lifestyle, and again, overweight, like you said, in females, and type 1 and type 2 diabetes, which are uncontrolled. They this kind of issues. So in grade 4 avian, when the head is lost, in grade 3 avian, avascular necrosis, when the complete head is lost, it also affects the cartilage, and that is the time when you need to think about a replacement. And that's what we are going to discuss about. What is the what are the implications, and when we do a hip replacement, what are the things that we need to see uh, in the, the who's a doctor and uh, what what
Yeah, yeah,
what all you need to look about in the hip replacement part. And today we are talking about something known as the dual
yes,
mobility hips,
yes,
which is a hot topic of discussion in the world now, because hip replacement, we will be going through how hip replacement started and what are the issues. Because when you look about hip replacement, people know, unlike me, lot of restrictions come right from going to the toilet to driving to having a good sex life to everything,
yes,
that hip replacement people are told
yes,
by the conventional doctors that they won't be able to do it. And today we'll be removing or rediscovering
yeah.
uh, the myths and clearing the myths of the people. And if you all can allow me to share the screen.
Yeah,
uh,
absolutely. I mean, I do have the same questions. Like,
so
after the replacement, can we really get away with a limb? Can the
so
pain reduce,
so
and
first of all,
etc.
we discussed AVNs, avascular necrosis of the hip, arthritis of the hip, fractures, complex fractures of the hips, and of course of the acetabulum. We come to a conclusion that doctor tells you you need a hip replacement, and so you have to take a call. And what is this dual mobility hip, and what is the latest in the hip replacement world? So this is us. We are patient specific inclined specialists with my team, and here's where we work. So what happens is, what is the history? The great Coming to the long story short, is Sir John Chanley in England. He started the hip replacement in something 1930s, and he was the father of the hip replacement. And still his patients during 1930s, uh, his patients are still, some of the patients are still doing good, holding out for uh, many and many years. And he experimented his own, and then hip replacement, again there was a parallel growing on in France, and then they started where in it's a center of traumatology in France. What happened is, Sir Gilly Bocquet, again in 1930, there were two guys, one from England and one from France, started doing hip replacement. And the concept was the cup and the stem. The cup was made of highly cross-linked polymer, and the stem with a non-modular metal head on the femur. And this is how it moved on from a smaller head to a larger head. Now, what is this? Sir John Chanley made the size of the head 22 millimeters with his experiments. But the issues started coming is, we would be able to walk and sit down but not to perform any activity more than 70 degrees. You will not be able to do any driving, any sitting cross-legged. And this part of the world, the Asian population, the American population, couldn't take the restrictions. And so the research started. First generation, it was the cemented cup, then the uncemented cups. In the 40-45 year old history that we are talking about, and now we are in 2020. So the sixth generation things have started. So what are the I will not go much into medical details, but uh, in 2019, the commonest cause of revision of the hip was loosening, and the loosening started with non-anatomical placements of the hip. What is that non-anatomical placement? Is the revision burden comes very, very heavy, because most of the hips that we are seeing now done by our seniors are coming for revisions because of lot of engineering failures. So that is the reason now our generation thinks that the first concept is it should be placed in the patient specific angle, like we do in the knees. And secondly, there should be no revision to the patient. So these are two focuses that the modern technology is focused on. Is there should be no revision, it should survive for the lifetime. Secondly, the patient should be able to have complete life in their style. There's a patient specific implantation. So this was how the hip replacement used to look like with a 28 head. And now we are going with a bigger head, that is 32 to 40 head, so that you will be able to do all the activities. And this is what Rajeshri I was talking about. Unlike that cup that I showed you, now we have something called as dual mobility. So
Mm-hmm.
uh, there are four linings for the cup now. The outer lining
Right.
that goes, I'll show you, that goes in the acetabulum. There is a metal inner lining, highly cross-linked metal, highly polished metal to microns. Then there is a polymer lining and then a ceramic head. So what happens is, like a natural hip, there is a concurrent movement of four different parts, and that makes it survive four times the normal hip replacement. So if the normal hip replacement survives for around 15 years, four times is 60 to 70 years. This is one beauty that we have got. And this is the latest, known as a dual mobility hip. So what is dual mobility is, your acetabulum fixed, but this part moves in conjuncture to the head. That's the head goes in clockwise, this goes anti-clockwise. So this goes anti-clockwise, head goes clockwise. So you're able to sit down, cross-legged, do namaz position. And this is this was the old hip. Now you can see there was only one liner and there was a polymer. But now we have four liners inside the hip, and the wear and tear of the acetabulum, the pressure is so much reduced because four layers are coming in. It's not a rocket science. When four layers come in, the wear and tear is so less and so very precise that the patient cannot dislocate. The patient will have lot of activities to do. I'll just share the activities that a regular head could do. The first mobility, with a 28 head that Chanley puts, we get only 76 degrees of freedom. So you can do some 70-degree movement. So that is like standing up, sitting down. But you couldn't sit on a bike because that requires more than 200 degrees of movement. You won't be able to sit cross-legged because it requires more than 270 degrees of movement. So when people are doing the conventional THR, the regular THR, with 95% of surgeons are doing, you will be able to walk and sit, but not do any other activity which a natural hip can do. So, but in dual mobility, now look at the freedom. It's more than 140 degrees in either plane. So it collectively it comes to 300 degrees of freedom, and that's what. Look at the freedom. Look at this. This is, if you can see, this is the stem, this is the head. Now this is complete spread out of the head. Like you can sit on a bike. Imagine this. Nothing happens to the head. The rotation of 220 degree. Now this is sitting cross-legged. Mandi ghalun bastanna. It is in the position because one cup is moving on this side, other cup is moving down. So that is dual mobility. It is a beauty of engineering. Only the surgeon has to put it in a perfect angle. So that's where this, what I was talking about, a good surgeon. See, now what happens is, you can see this degrees down written here. 45-degree anti-version, abduction, anti-version. Now what are these angles? Now, Rajeshi, the acetabulum in the standing posture, you look at it at three dimension. The first dimension, if you draw a straight line, can you see this angle here? This angle, that is inclination.
Yes.
Inclination. So we keep that inclination near about to 40 to 45 degrees. Inclination. Then something here is written as anti-version. Can you read this? Anti-version. What is the anti-version is, to the body, it is facing outerwards. Like I'm standing here, acetabulum is not looking on the side, it is looking towards the front. So anti-version and anti-version. So I have to put it in 20-degree front facing. So that is a natural how the acetabulum in a normal person is. I hope I am not going too much engineering, but inclination and the anti-version, and there is a adduction, so it has to be placed. So what all is this? This is a natural placement of the hip. And is it available for the bare eyes? We cannot do this with bare eyes, and that's where our robotics planning, which I keep on showing every time the 3D robotics come, which shows the patient's natural angle of inclination, of antiversion, of adduction, and adduction related antiversion. So a surgeon who is using a dual mobility hip, it's ideal that he places the hip using 3D robotics, so that Rajeshri, it goes in the patient's angle and the patient doesn't even feel that he has got a, you'll see some results, got a hip replacement done, because that goes in his natural angle. And that's where most of the surgeons are making mistakes, that they are not using the natural angles because they don't have gadgets and they don't have training for putting this kind of dual mobility hips. They are going for the regular fixed acetabulum and a fixed stem, which is done maximum in the world. But like I said, they don't give that kind of activities. So this is what I was talking about: the first layer, the second inner lining, innermost lining, inner lining, and the cup and the head. So this becomes the dual mobility system. So there is one, two, three, four. In the regular, it is only one. So we have multiple layers which are put in those particular angles so that the patient will be doing all the activities, and it is as good as a tripolar system. So that what happens is, the extra activities that is required, the head never comes out. So what happens, why the doctor tells you in a regular THR don't sit or don't do castle like that? Because it will come out, because it is fixed. But this is in mobile in 360 230 degrees, it will never come out, it never dislocates. Only you have to put it the right way. So there are a lot of papers. The survivorship is 94% more than the regular hips. There's a paper from US, paper from Germany, paper from from France, and again everyone, as of now, it started last 10 years. In 10 years, there is 95% survival worldwide of dual mobility hips. So now we are moving towards the third generation of dual mobility. We will be expecting 98% survival for the next 40 to 60 years of this hip without having any problem. So even the young people who want to get a replacement done, they should opt for a dual mobility uh, anatomical hip replacement. So in fractures, now you ask me what are the other reasons. Now this kind of fractures in young people where you cannot save the head, it was mandatory that you put screws, plates, and many a times the within 6 months there was avascular necrosis of the hip. But in here, if you go for a dual mobility, the survivor and the activity, you have only one surgery which is going to survive, make you survive for the next 40-45 years. You don't have to do a revision surgery, and you will be able to do all the activities that a normal person can do. And there are so many survival papers worldwide that everybody, the gist is it is surviving for more than 98% compared to the old surgeries. Now clinical there are some questions. Are clinical outcomes better in patients with dual mobility? Worldwide reports better. What is the dislocation rate? The commonest cause of medical failure in most of the juniors' hands, or the doctors who are not doing the hip replacement, they are afraid of dislocations. So look at here, there is zero dislocation worldwide, zero. The 2017 paper. So if you place it right, even if you do any activity like cross-legged or on a march position, if it is placed right worldwide, there is a 0% of dislocation. Otherwise, it was very, very huge in a regular hip replacement. So again, lot of studies. Now, if you see the inclination that we have put, low volumetric loss at 50 and 65-degree inclination. So if you put an inclination right, there is 0 degree of loss. And again, I will not go on the survival cycles. This is what used to happen with the regular hip replacement, Rajeshri. The polymer is to get worn out, it used to get dislocated, it used to get broken inside, because there was only one liner and the head. Can you see this head inside? The liner is worn out, the screws have come out. The This is because there are excessive pressures, because hip repaints a very mobile joint. So when you do a regular hip replacement with a single head and a single cup, these issues are going to be faced. So now what we do is the dual mobility, and I'll show you some patients. Uh, the take home message, I'll
Yep.
show you some result. Before that, the take home message from the scientific world is it is more than 30 years, 95% survivability, and there are no dislocations compared to the fixed bearing cups. So understandable is, out of 10, 9 people are going to be happy. What is that 1%? Any surgery, Rajeshri, from the dental surgery to the ophthalmic surgery to a skin scar removal, there is a 4% risk which is inherent. Any procedure. We have survival with these latest technologies, and huge range of movement what uh, we can achieve with all the activities I'll be showing. Now this is I'll show you the old one. Now this is a regular hip replacement registry, cemented on cup, head, single. This is uncemented but a regular one. Look at the cracks and all developing here. And this is what we do now, the dual mobility or anatomical hip replacement. See the angles, it is in the patient specific angle. This is his pre-op, this is his post-operative, it is almost the same. The center of the head is the same. The cup size is as inclined as the patient's. And this is what we do with 3D robotics now. The head size is as large and same as the patient's. And this is the latest in technology, where now we have got ceramic heads which survive for lifelong. And there are many examples. So this is the natural hip replacement with a dual mobility cup. And this is unique because bone grows on this. There is no cement, nothing used. And look at the activities people can do, Rajesh. The namaz position, sitting down cross-legged, riding bikes. Like this patient, he has a bilateral hip replacement done. Nobody even imagine that this person has undergone a hip replacement.
Very impressive. We wouldn't be able to tell.
Yeah. So what do you want more from a hip replacement? It was never ever possible to do all these activities with hip replacements. And this is what we can do with the dual mobility. And likewise, if we have some time, we can show what we do in 3D robotics, because every time we talk about 3D robotics, what is it? And now you can understand what is the importance of technology in our field.
Yeah.
And people should know that technology has taken us to such a great heights that we will be able to match everything. What I can share this. So any questions from that side, Rajeshri, so that
Yeah. So,
we will
well,
we'll
really,
answer according to the question. It was too
well,
technical, I understand, because
yeah.
hip replacement remains a technical issue in our field also, where people
Hmm.
people are doing hip replacement, but
Yeah. So,
regular hip replacements, and
mhm.
this comes a different ball game altogether.
So one question really that had come was, how early should we be doing this? Is it a better idea, like our knee replacements, that before it degenerates too much and it's going to become too traumatic? What's a good time to actually, especially now that we have the newest technology and yeah, the
Rajeshri,
dual mobility.
like I showed the slide, grade 1, grade 2, grade 3, grade 4. Hip
Yeah.
replacement should not be done unless and until you have changes on the acetabular side. Unlike the knee, knee you can do early, but hip we always give them more time to wait. So when should we do it, doctor? We should do it when there is an excruciating pain. Pain is not relieved with anything.
Yes.
You are not in grade 1 and grade 2 or grade 3 like the avian, where we do stem cell bone implantation. When you're in grade 4, only when the femur is involved, you should not do a hip replacement. The acetabulum has to be involved and it should be in pain. Second, if you get a fracture which is complicated, you should do it.
Yes.
Third is when you have a shortening.
Mm-hmm.
Before it shortens more than 10 centimeters,
Okay.
we can do this. Fourth is because of the excessive degeneration of the hips, the spine starts getting degenerated. And
Right.
the spine is known as something as kyphosis, scoliosis, where the spine starts degenerating. Before the spine gets degenerated, we should do this. But whenever you do this, you should ask your doctor, are you doing it robotic wise? Are
Okay.
you doing with the dual mobility? Are you putting a ceramic head there, which is natural shaped? We get a smaller ceramic head also. So if your doctor is not doing a dual mobility regularly, because dual mobility remains a bit complicated procedure to do.
Yeah.
And in the surgical process Rajeshri, I'll discuss 2 3 factors is the anesthesia, like I'll show, and what is 3D robotics. I'll just share the screen every time we show this, but again, we have an opportunity to
Yes.
basically, it is a planning. What we do is when the patient asks for a 3D robotics, we do a CT scan, and
Okay.
like the knee, we get all the uh, planes in the 3 dimensions, and we can really plan every bit and step, like the knee, like the hip, and all the implants are set before the surgery. We have special jigs made for placing those implants, and then we put it in the OR. Now in the anesthesia part also, like every time I add, we are giving computerized anesthesia.
Yeah.
There are no complete anesthesia. It's a very, very safe procedure, and it is done under local blocks. So patient is conscious, pain free,
Yeah.
and our approach to the hip is known as a direct anterior approach, where we don't cut the internal muscles. So when we don't cut the internal muscles, you can see what the activities all these people are doing, like sitting cross-legged and doing. So the surgeon has to have a very good anesthesia team. You should have a very, very good operation theater. You should have a robotic planning system along with him, and he has to be trained for this dual mobility, modern hips known as the anatomical hips that we have shown you. And luckily, Rajesh, today only one of my before our lecture, in my I was in the OPD, and one of my um, one patient
Mm-hmm.
came and I'll have a
Okay.
fresh, undiluted this thing to you. It might,
Testimonial for us.
yeah. Just today is I'll just is there on my WhatsApp actually, so I'll just show you.
Sure.
And my fellow just shared it.
But
I have not even. Can you see my this thing? I have not even. This is the
mhm.
hip replacement. See the anatomical hip that we have done, and look at his activity. Just fresh, might be 3 hours back.
Okay, great.
And he's a follower of Islam, and today he came down. Ki doctor, it's been 6 months now. Should I start? So we made him sit Indian cross-legged, which was never possible in a regular hip replacement. And might be next time we'll show that he is actually doing namaz, and like the photos I showed you, that they are doing namaz position, which was never ever possible with the hip replacement. And it is a life, like it is a today's patient. So it is we are so happy that these guys are doing so many activities which we never dreamt of before in a hip replacement. So it's a today's patient.
Wow, that's great. So I think really, I had all these questions which you've aptly really explained well, and especially very impressive, implant and the surgical methodology of dual mobility hips. And I mean, how could we could have never imagined doing all that your patients are really able to do, and very, very, very impressive when it
Actually,
comes to,
actually,
what.
Rajeshri, there are two things I will always tell that the underlying heroes are our biomedical engineers also. We need to we know to place those robots. We know to place those implants, but they are really made with sheer hard work. Because once computers came in, something we known as gate motion analysis came in. So after motion analysis, all this design started. We are lucky to be surviving in that generation where we can use this.
Yeah.
And but people should know that these are available in India now. There are American trained and UK trained surgeons like us who are doing them. We are continuously modifying. It's not I'm doing dual mobility from day one. It is a new technology.
Yes.
The technology started 10 years back in the US as a research. 5 years, all of us were knowing about it. Now, a couple of months down the line, we are doing this, and we are really seeing the difference. It has come to India, say, must be 1 or 2 years back, and so you look at the results, phenomenal results. Only thing, the surgeon should be able to perform because it remains a technology and surgical skill demanding surgery. It is a technical thing.
Yes.
It needs the talent to do it with knowledge of technology and the paraphernalia, the inventory, which the good centers where we work are giving us. We are lucky to be there in big cities, and all these are available, and not at a great cost, Rajeshri. The cost is almost the same.
Great.
Okay.
Yeah, I mean, that's where I was to about to ask you and reiterate, that in these type of surgeries, especially hip, we have known that it is very important to actually choose the right surgeon, and you really aptly explained, why and what type of surgeon, and what are the skills that he should have not just he's not going to have from day one, but that he has really relentlessly honed them, and try to learn the technique
So
well
at
and
least,
practice it
Rajeshri,
well.
we should have done near about 500 hips to 600 hips, and then you shift to a dual mobility uncemented THR, because uh, it takes a technology, it takes the knowledge of it is not one layered, it is multiple layered. You should know to save the muscles, you should know to do it super fast, you should know how to use the inclination angles, and you should always know what is the right size of the head to be cut during the surgery and what parts to be saved. So you have to save the collar of the stem, and a lot of technical issues which we learn over time. And I feel people who are doing dual mobility now are one of the finest surgeons of the hips, and we are blessed to have nature given us the talent to do that.
Yeah, and that gives you the opportunity to become an engineer along with being a surgeon. So
Always, I was always wanted to be an aeronautical engineer, and here I am. So I'm in the best of both the worlds, where I am an engineer and I am a doctor. So it's better to be an having a payslip of a doctor and be an engineer, not the other way.
well, yes.
So best of both the worlds.
Yeah. So apart from that, then because you've covered the aspects of the surgery so much, really in depth, so the patients will also know what they should expect after the surgery. But apart from that, I know that you not only completely focus on your own surgical skills, but also when it comes to your team approach, and when it comes to the recovery, trying to get your patients out of the hospital on their feet as soon as possible.
So yes,
So,
Rajeshri, nice you came out. And all these days I never said this, but today, luckily, in these COVID times, we are, I think in Pune, we are one of the highest number of joint replacement surgeries is done with my team as an individual surgeon, not an hospital, but as an individual surgeon. And we are proud of my team. We have people working day in and day out for us, including you. So there are layers and there is a complete circle to my team. So when I operate, there are people down there who are working. See, Rajesh, we have started, we understand this is a COVID time. The
Yes.
first thing what we started now, since October, July, October, is to have a very, very cheap rate
Mm-hmm.
to our patients without
Yes.
compromising the implant.
Yes.
So we have worked, especially in Jahangir, where we work more, that we have reduced the medicine cost by constraining the use, by restraining to selected medicines, making a kit so that patient saves massive amount of money. No other team in, might be in Maharashtra or India, doing that. I'm very proud of that. Then we are working, we have really tied up with good companies to get a good rate. So ultimately, now we can do the hip replacements in half the rate that we were doing, because now people really don't have money.
Yeah.
Because of that factor, they are sitting home, or they are getting operated in a place where they are experimented upon by
Yeah.
learning doctors or in teaching institutes, where complications can happen. So people should understand that we are giving the same services, but this is again possible only with the team. So there are people who are counseling the patient. There are people who, they are, my team discusses finances with them in consideration to the present time. And still we are doing the same technique, same, we are not compromising on any quality part. But yes, where the money can be saved, it has to be saved, because that is the rule of the land now. And this is the first time on this platform or any platform we are talking about money, because that's the reality, Rajeshri, now.
Yeah.
Because that's the reality. People don't have no jobs, and I have seen people. So out of 10 hips that we did this month, must be 6 were 5 were complete charity patients, but all of them got an American implant with the big head and
Wow.
whatever I talked, river. And we use, we can save on the surgical fees, and we can save on the medicines, but we should not compromise on the implants and the operation theaters. And people should understand that don't save money unnecessary.
Yeah.
Just because you don't have money doesn't mean you can't get a good service. You have to search for it, and we are giving it.
Wow, that's amazing to know that you are really trying to think from the patient's angle, not only when it comes to the technique and their outcomes, but also the affordability side. And yes, it is totally needed to be humane in these times and trying to be supporting them as much as possible. Because again, a lot of them are not able to do their day-to-day activities. They are a lot of people's professions are attached to being able to perform well. So it is important for them to go through these surgeries, and it is important that they don't delay further. So from that standpoint, it's again really a noble cause that you are addressing from your side. And of course, congratulations on being able to do those many surgeries even through these times, and keeping your patients, especially those ones who have been waiting for too long, comfortable by being able to get their surgeries done. Also, when it comes to going back again to your team approach, when it comes to explaining to your patients, being with them, answering their questions, and at the same time, when it comes to physiotherapy, post-surgically, making them comfortable, so that the outcomes are even improvised. What are the steps
Yes,
that they
Rajeshri,
really consider?
that's one question, especially for the hips. When it comes to revision hip or that kind of stuff, we have seen excellent results in patients who have good nutrition in their younger ages, who have been into good protein intake, and who have good bone mass. They never get infection. Their recovery time is very, very less. And the pain factor is massively less, and recovery again means going back to their original activities. It is very fast, it is super fast. So if like the team approach, what we said is, I always focus on, after the third day of surgery, we really hammer the patient with good nutrition, the values of good nutrition, and the value of good healthy lifestyle. And I always have been a avid user of your flexi food and the
Yeah.
pancreas, where every patient gets it. So today I literally we gave it to a shoulder patient who's a Jain patient. She had an issue with the red dot, but I said, look, when it's muchami that come, you have to say sorry. But
Yeah.
since you are in this prapancha, you need to have the the medicine that is going to make you pray. If you are having on the bed anyway, you're not going to pray. So take it for some time,
Correct.
recover, and go back to your activity. Because Rajesh, nutrition becomes a huge part, especially when you have a revision surgery, when you have a lot of muscle loss.
Yeah.
We have seen one more patient where uh, he it was a fourth surgery that we did on him, and there was a complete hollow and a loss of muscle. And he was a Jain patient from Mumbai. We did a hip replacement, and every fortnightly, 7 days, he used to come with a blood filled area. We had to drain it out, and
Wow.
because there was a muscle loss. And then we sat with him, we counseled him, ki, sir, please understand, it's a unique case report, um, and the patient would be has given a testimony also, and where we started him on heavy protein diet with 40 food and flexi food. And believe me, he has developed a complete hamstring mark,
Wow.
and he was thrice operated for infection. And we, the fourth time we did, the patient is now 1 year post surgery, doing all the activities. He is a pharmacist, he goes to his multiple shops, and he was in home for 9 months before, because he was draining pus and a lot of other issues because of the failed previous surgeries. And this is one couple of patient where we really converted him. And he said, forget it, sir, now I'm going to start on eggs. He said sorry to his religion part, and literally 7 to 8 eggs we started a day. He went on flexi food, 40 food, complete muscle recovered. Infection has been totally controlled. Now this is one thing which we need to understand, that nutrition, infection, nutrition recovery, nutrition results are one and the same. Surgeon will place it well, but to maintain it,
Yeah.
you need to have a good nutritional support. And next time we will have this kind of incoming lectures, that once we do all this kind of hi-fi surgeries and this hi-fi technology, what is about the recovery? And that is one big gray area, where most of the freelancing surgeons, they go operate and forget it. So it's better that a surgeon is at a particular center, sees the patient every time. That is one thing you have to choose. Second thing, he should have a excellent physio and nutritional support. Only physio and lack of follow, which I've seen in a lot of high volume centers. We give patients time slots, but we see the patient ourselves. We don't rely on some junior just seeing it because I have a high volume and I want to go home early. So I don't like that kind of stuff. So Rajeshri, all the patients we are seeing personally, online, offline, in the OPD, but we give them time, and in that we really explain them nutrition.
Great. So yeah, of course, we will be doing a specialized, program on that. But it's amazing to know that, and of course, I believe in it that even pre-surgically, patients should be given nutrition and post surgery. The way you're
I
managing.
have converted people from pure veg to couple of,
Wow, that's
but
incredible. But
I mean,
it is great because that's one thing in India that we don't understand, that even if people are eating non-veg, they eat non-veg because they're not eating it as nutrition.
yeah,
But
the eating is for ego, so
yeah.
it should be a
So
balanced diet.
yeah. So I think that's great that
So
they
either
have
way, too much of non-veg, too much of veg, anything too much is bad.
bad
The
totally
balance
totally.
should be, and that's
Yes,
what we're telling them, and the wholesome food without
yes,
supplements possible. So supplements are
yes.
going to be needed.
Yes. Yes, and I like I was talking about earlier, the anti-inflammatory agents, the proteins that which you emphasized. Balanced means, of course, in terms of the macro and micronutrients, but also acidic and alkaline foods. All of this that has to be managed, and we do manage them with your patients holistically, trying to understand what is the condition, what is their current status, and based on that, we give them personalized plans. Again, work hard on making a new one for them. It takes a lot of time and understanding to be able to put that together. So it's always a pleasure to do that with you and for your patients, Dr. Albert, because that really improves your outcomes further down because you're already taking so much of effort in bringing those right techniques, practicing them, and making sure that your patients get the best. We know that you're going to be extensively taking this work forward in terms of your hip replacements, just as you have been very, very successful with your knee replacements. So that's again where we would want to take the education more actively forward and, of course, support you in your complete integrative approach in giving the best to your patients. It was really a very complete sort of session with you, right from understanding when you need it, when you need a hip replacement, and the right implants and the right methodology for it. Having a complete approach towards it, how to take care of complications, what outcomes we should expect, and such brilliant outcomes you showed through the testimonials which your patients have shared, and especially the freshest one which you shared from today with us was incredible. We are actually going to wish you more success in these surgeries, but of course we will be continuing this series with more number of such advancements and advances that you are bringing to the patients and working really hard on it day in day out. I would definitely, like always, like you say, I give you the chance, though I'm a woman, but I would of course want you to give a last closing remarks and takeaways for patients that they should remember when it is to take care of their hips. It's again very, very important, and you realize that only when you are on the other side of 40 and 50. But if you can give those inputs to them so that they
So
can take care of themselves, and of course.
especially for
Mhm.
women, it's the problem is the because of the hormones that change after 40s. They have a lot of fat depositions on the hip area, so you have to really work on those muscles. You should do a lot of hip area exercises like squats, lunges, especially cycling. You should cut down on your carb intake, take proper protein, and likewise you said, Rajashri, the issue of osteoporosis, like last time we discussed, you
Yes.
should take care of that. Vitamin B12, D3, and calcium intake, and magnesium is one thing that you need to have in your orthopedic mindset, that magnesium and calcium and zinc go hand in hand. So the supplements like vitaminolites and forty food where you have this magnesium, you should have them, uh, and added boron, so that this micronutrients, if you have, you will have less of these issues of degeneration. And whenever you have pain more than 15 days, you should consult a surgeon who is doing this kind of work. And uh, it's is a public perception that why we are changing the perception. The people should know that this kind of work is been going on around in our hands and our places. So like I would add one I hope you understand Urdu. Somewhere it was written for Shahin Shah Akbar that It's like when the public demands are met, it's like it goes like this: Gar दीवाने आम न हो, गर दीवाने आम न हो, मतलब दीवाने आम and दीवाने खास Akbar had.
Yeah.
So, but when he went from Diwane Am to Diwane Khas, so when you look at the patient specific angle, patient specific needs, the society specific needs, Gar Diwane Am na ho, koi Akbar na bana, जो तुम्हारे सर झुके तो शहंशाह मैं बना. So when you meet with the public demands, with the law of the land, what the people need, my people need to sit down, do namaz, do puja. Just because I'm in UK train, I go and put an the joint in their way, it is not going to make me Shahenshah. It is going to make when my people will get what they want, and I should be able to deliver what they want. So gar दीवाने आम न हो कोई अकबर न बना जहां तुम्हारे सर झुके तो शहंशाह मैं बना. So that is what they used to say, because when Jalaluddin became Akbar, because Akbar was the name given to him by the people. So tomorrow, I feel when I'll retire, the people should know me as a people's doctor, understanding and presenting India that this is what my people need. My people need to go to the farms. My people need to pray. My people need to do namaz. My people need to sit in the temples, kneel on the. We are that way. We need Indian toilets.
Yes.
We need Muslim toilets. So why should I give a joint in the knee and the hip, which will not allow them to do all this? So you should choose the right doctor, the right nutrition, and considering what we need, we should the surgeon should also not always be westernized in their thought process. There should be a bit Indianized thought process that this is my people what they're needing, and that's what we are giving it, Rajesh.
Totally. So I can't
I think too
agree
much,
agree
too much,
more.
too much of
Philosophy, but
philosophy,
yes,
and
yes,
today I'm in the
that's
mood. I
true.
think so.
So that's true. I mean, when we are talking about tailor-made, solutions for them, they should be India-specific and they should be specific to our beliefs and what we practice as professions out here, and not just what we do, what we as engineers relentlessly doing overtime jobs at home. So, really aptly addressed topic today, Dr. Albert, and it was a pleasure to be with you today. For such an extensive session with all the
Yeah,
detailed
it was
input.
I made it sound a bit, but it's a big topic. It's a
Yeah,
topic for us to learn also. We are teaching it also, but it remains a complex topic, and it remains a very serious topic because hip replacements are more done in India than the knee, and a lot of failures are seen. So,
yes,
and when I'm revising couple of them after Diwali, but it becomes a very difficult process, Rajeshri, to revise. So again, I said, like, public demand, we should have one surgery, that should be a final surgery.
sure, yes, and so I think are we planning to be here because next weekend, next Friday is going to be Diwali. We're going to try to do that. Else, of course,
We'll be
we will.
repeat telecasting
Yeah,
for
yeah,
shows. We
yeah,
will be here, but with
yeah.
Diwali to
Else we
everybody
are.
who's watching this.
Yes,
So I think next Friday we can actually,
yeah,
but after that Friday we can. Next Friday
yeah,
we will definitely come down, but I think next Friday we should talk about something related to nutrition. It should be a
yeah,
debatable topic because
yeah,
Diwali and nutrition
yeah,
are enemies.
yeah.
Because
True.
today I think we are live, so
Yeah,
I was I go to run with my daughter, and
sure. Yeah.
we were discussing. A couple of women who run, oh God, I have to run more because Diwali is coming. I think if that is the motivation, it is
Yes.
wrong. I want to eat, and then I was just overhearing, like, Diwali hai, I am going to eat more, but I am going to run more. Okay, if that's okay. So in Diwali, try and keep your nutrition to the limits, because
Yes.
sweets and it's a time where you need to control,
Yeah.
because everything is available.
Yeah. True. So yes, so we will try and be back with a nutrition approach next time. And absolutely right, because Diwali we are eating too much, and how to not just how to take care of your bone and muscle, but also your digestion and your weight, which is important. So we will try to address that the next time. And viewers, thank you so much for coming and encouraging and always being with us, and making our show successful by actually learning from the series that we are running. Thank you, Dr. Albert, again for being with us today. And I would also like to thank the RSDA Energia team for always being with us, helping us with all the technical support that is needed, and also circulating most of our shows to widest of the audiences that you can reach us out to. With that, I will just play a promo of RSG Energia as a concept, their products, which of course are very effective in a lot of orthopedic, ailments that patients are facing as well. So